Welcome back to this next video in which we are discussing irritable bowel syndrome. So in this next video we have 3 points that we want to discuss. The first is the diagnosis of IBS. The second is possible explanations as to why individuals get IBS. And the third and final thing that we'll end with is the current medical treatment for IBS. So let's begin then with diagnosis of IBS. So remember in the previous video we said that the primary symptom of IBS is abdominal cramps that are classically present within the left iliac fossa region, although we've said they can be present on other portions of the abdomen as well. And remember, we believe that these are caused by idiopathic spasms of the colon, and since it's usually in the left iliac fossa, it's usually this portion of the lower descending colon that goes into spasm. In the previous video, I told you about how important it is to be aware of these other conditions, simple constipation and food intolerances, that can often cause these secondary symptoms of IBS, but which won't give rise to the primary symptom of the abdominal cramps. What I now want to talk about is how to distinguish between IBS and these conditions that we've written over here, these inflammatory conditions of the gastrointestinal tract that can also give rise to spasms of the colon, in this case not idiopathic spasms because they're triggered by the inflammation and therefore need to be distinguished from IBS. And IBS should be a diagnosis of exclusion. You should rule out all of these 3 things prior to making a diagnosis of IBS, because you don't want to conclude that the abdominal cramps are idiopathic when in fact they've got an inflammatory cause underlying them. So you need to rule these 3 things out before you make this diagnosis. So I just want to now talk briefly about how you rule these things out. So let's begin with gastroenteritis. Now, gastroenteritis, it's an infection of the intestine, and there are 3 major categories of pathogen that can infect the gastrointestinal tract. There is viral gastroenteritis, there is bacterial gastroenteritis, and there is also protozoal gastroenteritis. And the reason that I distinguish between these 3 different forms is that they last for a different amount of time, and they are of differing severity. So, viral gastroenteritis is usually extremely mild. It usually only lasts for a few days. The classical virus to give rise to it, classical viruses that give rise to it are norovirus, rotavirus, adenovirus. Everyone gets viral gastroenteritis from time to time, and it causes mild abdominal pain that will usually go in a few days' time, and it makes you feel very unwell. Bacterial gastroenteritis, so obviously it's quite obvious how you distinguish between viral gastroenteritis and IBS. If the symptoms have only been present for a few days, you do not start thinking IBS, you think viral gastroenteritis. Bacterial gastroenteritis, it lasts for a little bit longer than viral gastroenteritis. Classical bugs that can give rise to it are Campylobacter jejuni, Salmonella species, possibly Shigella species, though that gives rise to a much more severe diarrhea usually. And these can last for longer periods of time than viral gastroenteritis. It's more severe bacterial gastroenteritis. It can last for weeks, whereas viral gastroenteritis is usually days. And bacterial gastroenteritis, you can be treated with antibiotics if you're not getting better from it on your own. So again, if it's only been present for a few weeks, you don't generally think IBS. Again, you start to think bacterial gastroenteritis or maybe just a long viral gastroenteritis. So if these symptoms of crampy abdominal pains have only been present for a few weeks, think infection, viral or bacterial gastroenteritis. And that's quite obvious how to distinguish that between these other chronic conditions. However, the one that's important actually to talk about is protozoal gastroenteritis, because this can go on for a very, very long time, months even. And there are 3 major different types of protozoal gastroenteritis, and they've all got massive great names, so I'm going to write them down. So amoebiasis is one, giardiasis is another one, And then the final one has a massive great name that it took 5 years of medical school for me to learn how to pronounce. Cryptosporidiosis is another form of protozoal gastroenteritis. So the reason I've written these down and I'm stressing them is because they can cause a gastroenteritis that goes on for months and months and months. And if that happens, of course, that starts to make you think of these other conditions like IBD, celiac disease, or IBS, these chronic medical conditions as opposed to these acute infections. So it is important to be aware of these protozoal forms of gastroenteritis because they are a possible differential for these chronic conditions of the gastrointestinal tract. So, how do you test them for an infective cause of abdominal cramps? Well, what you need to do is a stool sample, and then you send this off to the laboratory, and the clever people in the laboratory can do microscopy on the small stool sample, so they can look at it underneath the microscope and have a look for protozoa and bacteria. And they can also do culture. And by the way, none of these are going to detect viruses. You cannot see viruses underneath normal microscopes, and you cannot culture viruses as well. So these are mainly for bacterial and protozoal gastroenteritis. But viral gastroenteritis, usually it's very short and it's self-limiting. So it's usually pretty obvious if someone's abdominal cramps are due to viral gastroenteritis. So we're more talking about bacterial and protozoal gastroenteritis in this case. So the patient will need to give a stool sample, it will go off to a laboratory in a hospital, and the very clever people there will look at it under a microscope, then they'll take a little bit of the sample, smear it on some sort of growth plate, and incubate that plate for a certain period of time and see what grows and come to the conclusion of whether the abdominal cramps may well be explained by an infection of some sort. So that's the way that we can find out if the abdominal cramps have an infectious cause by doing a stool sample. Let's do celiac disease next, and then we'll come to IBD last. So celiac disease, as I explained in the previous video, this is a autoimmune disease that is triggered by gluten. So when an individual eats gluten, their body then attacks the small intestine. And if they do not eat gluten, the autoimmune disease does not occur. So that's what's brilliant about celiac disease, that as long as you follow a gluten exclusion diet, the autoimmune disease will stop. Of course, following a gluten exclusion diet is difficult, but you can cure the disease by following a gluten exclusion diet, which is, compared to other autoimmune diseases that are incurable, it means that it's a nice autoimmune disease. So, how do you test for celiac disease? Well, the first line test that you need to do is a test for anti-TTG antibody. So remember, TTG stands for tissue transglutaminase, and it is an enzyme that is produced by cells of the small intestine and which is used to digest gluten. And the reason, as I explained in the previous video, that it gets an antibody produced towards it in celiac disease is because gluten binds to it. That new complex, we believe, is a different immunological target, and then the body can produce an antibody against that in people with celiac disease. So we test for the presence of the antibody directed against tissue transglutaminase, and we can do that for a simple blood test. So this is the first line check for celiac disease. You check if someone's got anti-TTG antibody. However, if that comes back positive, it doesn't automatically mean that the individual has celiac disease. That's not enough to diagnose celiac disease. If it comes back negative, then we can rule out celiac disease. We can say you don't have celiac disease. But if it comes back positive, that's not enough to make a diagnosis of celiac disease. What then has to happen is the individual has to have an esophagogastroduodenoscopy, which is where they put an endoscopic camera down the esophagus, through the stomach, into the small intestine, and then they look down in the small intestine. They'll see inflammation if the individual has celiac disease. Then they take a little biopsy of the intestinal mucosa, and they send that off to the people in the laboratories, and the people in the laboratories look at it under the microscope, and they need to see that the villi of the small intestine have been destroyed, so-called villus atrophy, in order to make a diagnosis of celiac disease. So that's the key phrase for the diagnosis of celiac disease. You need to find villus atrophy in the small intestine, and to do that you have to take a biopsy after doing an esophago-gastroduodenoscopy and OGD. Right, so that's how you diagnose celiac disease. So first line test for celiac disease to rule it out would be an anti-TTG antibody. So if someone does have IBS and we're doing the checks to make sure that they don't have these conditions, what we would do is a stool sample to rule out gastroenteritis, and we'd also do an anti-TTG antibody test to rule out celiac disease. Of course, we wouldn't send them for this quite invasive procedure unless this came back positive. But if they don't have this, then this will come back negative, presumably, and we won't ever progress to this invasive procedure. IBD then, finally, how do we check for inflammatory bowel disease? Well, the way that you can do this is by looking for, well, one of the common tests that we do for this is we test for fecal calprotectin, and we also look at the inflammatory markers within the bloodstream. Now, of course, all of these things, and I'll write them down in a moment, they could also be positive in these other two as well, so gastroenteritis and celiac disease. But if it's gastroenteritis, you'll also find stuff when you do the stool sample, microscopy and culture, and if it's celiac disease, you'll find a positive anti-TTG antibody. So let me just explain that in a moment once I've written down what we do. So we do blood tests, and we do blood tests for two inflammatory markers. So these are called CRP, C-reactive protein, and ESR, erythrocyte sedimentation rate. These go up in response to inflammation occurring within the body, and they go up in response to inflammation occurring anywhere in the body. However, if you have a lot of inflammation occurring in the gastrointestinal tract, that is enough to drive your inflammatory markers up. A more localized test for inflammation in the gastrointestinal tract is fecal calprotectin. This is something that we can find within the stool. So again, it involves a stool sample needing to be collected. And it is a protein, calprotectin, that goes up in response to inflammation in the intestine. So you'll find calprotectin present within the stool if that individual has inflammation occurring within their intestine. So let me make this clear as to how we're going to go about ruling out these other more serious inflammatory conditions of the gastrointestinal tract. So let's say we have a patient who is coming to see us because of horrendous abdominal cramps that have been going on for several months now. If it's a several-month history, it makes viral and bacterial gastroenteritis very unlikely. It is, however, still possible that they may have protozoal gastroenteritis. We also need to rule out IBD and celiac disease. So what we're going to do is we're going to do blood tests where we look for these inflammatory markers CRP and ESR, and we're also going to take a stool sample and we're going to look for fecal calprotectin in their stool and look at their stool with microscopy and culture. We're also going to do a blood test for anti-TTG antibody. If their inflammatory markers come back raised, that suggests that they have inflammation occurring somewhere in their body, and it is potentially coming from the gastrointestinal tract. That does not tell us that it is necessarily coming from the gastrointestinal tract, and secondly, it does not tell us which of these three conditions it is, because all of these are inflammatory conditions. It just suggests that there may be an inflammatory pathology rather than an idiopathic pathology, as is the case for IBS. If fecal calprotectin comes back positive, so if they find calprotectin within the feces, that then says, okay, you have got inflammation in the gastrointestinal tract. So if these are positive and this is positive, that's sort of pointing us to the direction that the inflammation that has raised the inflammatory markers is coming from the gastrointestinal tract. But again, that does not tell us which of these three it is. It just tells us that there's inflammation rather than an idiopathic pathology. What we then need is the stool sample for microscopy and culture. If that comes back positive and tells us that they've got giardiasis, then of course that's the diagnosis. If that comes back negative, however, that means that it is not an infection, so we can rule out gastroenteritis. We then need to look at the antibody test for TTG. If that comes back negative, it means they do not have celiac disease. If that comes back positive, they might have celiac disease, and you need to send them for an OGD to look for villus atrophy. Be aware that some people will have a positive anti-TCG antibody but do not have celiac disease. Let's say they do not have celiac disease, so let's say this antibody comes back negative, or alternatively, this comes back positive, but when you send them for the OGD, they don't have villus atrophy, so they don't have celiac disease. In that case, we've got positive inflammatory markers, positive fecal calprotectin, but negative for gastroenteritis, negative for celiac disease. Then you would start to think they've probably got inflammatory bowel disease. And the further tests for inflammatory bowel disease that can be done are again an OGD. So if they've already been for an OGD, they would have seen inflammatory bowel disease then. But we also need to have a colonoscopy in this case, where they stick a camera up the other end, the back passage this time, to look at the colon, because the OGD can only go so far. It can't make its way right down into the colon. It just goes into the duodenum. So both of these endoscopy approaches will look for patches of inflammation of the gastrointestinal tract. We'll take biopsies. The clever pathologists can then look at them under the microscope and confirm diagnosis of IBD. So that's how you would diagnose IBD and distinguish between these three. However, if all of these tests come back negative, then we can rule out all three of these, and that is when you make a diagnosis of irritable bowel syndrome. So there's the complicated explanation of how you come to this diagnosis. It should be a diagnosis of exclusion. You should do a stool sample to rule out gastroenteritis. You should do blood tests for anti-TGG, the inflammatory markers, and you should also look for fecal calprotectin. Only if all of those come back negative do you then start to consider that the diagnosis is irritable bowel syndrome. Right. Next then, I want to talk about possible explanations for irritable bowel syndrome. So we don't completely understand it, however, we do have some ideas about possible explanations, and there are two major things that you should be aware of. The first is that many people with irritable bowel syndrome also suffer from anxiety problems, usually generalized anxiety disorder, and there is a very good correlation between irritable bowel syndrome and anxiety disorder. So it is possible that having anxiety, being in an anxious mental state a lot of the time, that can lead to the colon going into spasms in this way. If this doesn't make sense to you, what I would advise you to think about is the last time you had a really important exam. You will be nervous, you'll be in an anxious state prior to that exam. And do you remember that your tummy starts to feel very, very weird before exams when you're in a very anxious state? So hopefully that anecdote may well start to convince you that your mental state can affect your gastrointestinal tract. And if you imagine someone with generalized anxiety disorder, they could be in that same anxious state that you get into prior to an exam all the time, and therefore it could be having effects on their gastrointestinal tract all the time. So I hope that makes you think that possibly it is plausible that mental status, anxiety status, can influence the behaviour of your gastrointestinal tract and could possibly cause these idiopathic spasms of the gastrointestinal tract. So I'm just going to put this here. So we're trying to give possible explanations as to why this happens. Fundamentally, it is idiopathic. We don't properly understand it yet. But one of the school of thoughts is that it's related to anxiety. More evidence for this. Irritable bowel syndrome classically affects a certain group of people, and that is young and middle-aged women generally. And young and middle-aged women are also at higher risk of suffering from anxiety. So that's another correlation between the two. So of course, if you do think that anxiety and stress is potentially the cause of someone's irritable bowel syndrome, then the treatment needs to be to treat the anxiety, and the first line treatment for anxiety would be an SSRI drug, a selective serotonin reuptake inhibitor, such as sertraline or citalopram. The other big school of thought as to why individuals get IBS is that it's triggered by some sort of food. And the classical one that we all get taught in medical school is tomatoes. However, for different people, it may well be different foods. So, Again, IBS is these idiopathic spasms of the colon. It is possible that these spasms could be caused by eating a certain food. Of course, the food that you eat will go through your intestine, it will go through your colon, and therefore it is possible that in certain individuals, certain foods are actually triggering these spasms of the colon. This is the other big school of thought, that it's triggered by certain foods. And for different people with IBS, it can be different foods that are triggering the colonic spasms. The classical one that many people have eliminated from their diet and ended up curing their IBS is tomatoes, but for different people it could be different things. So how do you then advise the patient to try and find the food that could be triggering this? Well, the common thing that we advise people to do is to keep a food diary. So what this involves doing is writing down what you eat on a daily basis, so what you have for breakfast, what you have for lunch, what you have for dinner, and also keeping a log of what your symptoms are like, how bad your symptoms are, and then you can look at this diary and try to find correlations between what you've eaten and how bad your symptoms are. Also bear in mind the time frame between foods going in and getting to the colon. So remember, maximum 2 hours in the stomach, maximum 6 hours in the small intestine, and then they get into the colon. So it's going to cause the problem once it's actually in the colon. So you need to factor in that time difference between eating something and it actually making its way into the colon. You also need to think about which part of your colon is being affected. So where are you feeling the pains? And if it's the classical place, which is the left iliac fossa, that of course is right at the end of the colon. So you would then need to factor in the amount of time that it's going to take to get round the colon to that end portion of the colon. If you do find some sort of pattern, then you can try obviously performing an exclusion diet where you remove certain things from your diet. However, I want to give a warning here. Many people criticize Western doctors because they feel that we underestimate the importance of diet for health. They think that we overprescribe drugs and underprescribe healthy eating. IBS is one of the conditions where we do acknowledge that many people with this condition, it may be triggered by certain things that they are eating in their diet. The reason that we steer clear or get a little bit afraid of telling them to start messing around with their diet is because some people, when they start doing these exclusion diets, can become a little bit fanatic with it. And the last thing that we want to do is trigger someone to go into an eating disorder. So let me just give you an example of what can happen. So if we start telling people to mess around with their diet and start taking things out of their diet that they eat every day to see if their symptoms get better, what we would like them to do, we'd like them to do it in a sensible, rational, scientific way. We'd like them to say, okay, I eat, let's say, tomatoes every day. What I'm going to do is, maybe this is responsible for my IBS, I will stop eating tomatoes for, let's say, 3 days, and we'll see if there's any improvement in the symptoms after those 3 days. And then after those 3 days, if there have been no improvements in the symptoms, we would like them to then say, okay, it's not the tomatoes, I'll put the tomatoes back in and I'll try removing something else. That's what we'd like to do, because, to be honest, after 3 days, you should have seen improvement. In most people, the food will have completely gone through you by that point. And in IBS, there is nothing physically wrong with the intestine. It isn't like celiac disease, and I just want to come back to this. So in celiac disease, we say that once people have given up gluten and have gone on a gluten exclusion diet, the symptoms of celiac disease can take up to 4 weeks to start to go away. The reason for that is because there is genuine damage that you can be seeing to the intestine. There is inflammation and villi have been lost, and once you've given up gluten, the autoimmune attack is going to stop. However, it's going to take many weeks for the intestine to then heal down and all the inflammation to go and the villi to grow back. That is why it takes 4 weeks for the symptoms of celiac disease to go away after doing an exclusion diet. In IBS, when you actually look at the intestine, there is nothing physically wrong. There is no inflammation. So they are idiopathic spasms of the intestine. So the symptoms should go away very quickly after excluding the food that is causing it, if it is the case that it's being caused by a food substance. So you should only be performing exclusions of certain things in the diet for a short period of time and seeing if you get any improvements. And if you don't get any improvements, then it's not that thing that is causing it if you've got IBS. The worrying thing that people often do when they try doing these exclusion diets is they eliminate one thing, they don't see an improvement, and then they eliminate another thing, but they don't put the first thing back in, and then they just keep going on, gradually cutting more and more and more out of their diet, and end up with an eating disorder, end up losing huge amounts of weight, and that's absolutely what we don't want to trigger. So that is why doctors get a little bit scared about telling people to start messing with their diets, because people can start becoming fanatic with it and excluding more and more and more from the diet to the point that they end up with an eating disorder and not ever putting things back in. However, if you do want to do this, please do it sensibly, rationally and reasonably, and exclude one thing at a time. Do it for a short period of time. If you do a few days, 3 to 5 days maximum. If you do not see any improvement, then you can keep that thing out of your diet forevermore. It is very unlikely that you will see any improvement because of that exclusion. So you can put that thing back in at the end of the 5 days and then eliminate something else and keep going through by trial and error in the hope that you may well find the trigger that is causing your symptoms. So if you are going to do an exclusion diet, please do it sensibly. Don't just exclude more and more and more and more. Common things that people try excluding are tomatoes, because that's the one that doctors advise them to start with, but also dairy and gluten are two of the major food groups that people try excluding. Again, those two are very, very difficult to exclude because so many things do contain dairy and contain gluten. So again, if you've got IBS, just do it for a few days, and if you do not see improvements, then it is not that is causing your symptoms, and you can put it back in. Do not start just excluding more and more and more to the point that you're only eating hardly anything anymore. Okay, so those are the two school of thoughts as to why people get irritable bowel syndrome: anxiety and food triggers. And it's possible that in different people it's different things. So in some people it may be anxiety, and in others it may well be a food trigger. It's not necessarily the case that the pathogenesis of these intestinal spasms is always the same. What they have in common is that we don't understand them properly at present, so it's called idiopathic. So that's why. Let's now move on and discuss the current medical treatment for irritable bowel syndrome. Now, unfortunately, the treatment is not brilliant. It, in some people, is successful, but it isn't brilliant. We give drugs that are called antispasmodics for IBS. And the name says it all. They are drugs that aim to prevent the colon going into these spasms. They hope they stop the intestine going into spasms. There are two major examples of antispasmodics. One is mebeverine, and the other is Buscopan, but Buscopan is the brand name for it. The full name for it is hyoscine butyl bromide, and that's why we don't usually call it by its proper name. So the common brand name, at least in the UK, for hyoscine butyl bromide is Buscopan. Okay, so these are the two major drugs. They reduce the likelihood that the colon is going to go into these spasms. In different people, they have different levels of effect, and many people do find them helpful. Generally, we advise that people take them as a relief agent. So when they have a really, really bad abdominal cramp that is not getting better, they can take one of these drugs and hopefully that will relieve the spasm. It will make the intestine come out of the spasm. In people with really, really severe IBS, where they're getting really bad cramps every single day, then what we can do is prescribe these drugs so that they're taking them on a regular basis to try and have a prophylactic effect to prevent the abdominal cramps from occurring in the first place. The other little thing that I want to discuss as far as treatment is concerned is we can also give laxatives. So you remember me saying that one of the secondary symptoms of IBS is that people can end up with constipation because the intestinal spasms can push contents backwards in the intestine, and then too much liquid can be absorbed, and it can end up very, very dry and very, very difficult to pass. So we can also give people laxatives if constipation is a big problem within their IBS. So some laxatives that we can give, lactulose is a first line laxative. Other laxatives, ispagula husk is another one. Because that's a difficult name to pronounce, we often call it by its brand name in the UK, which is Fibogel. And macrogols are another key laxative. And these, I've kind of put them in the order of efficacy. So lactulose would be the first line one. It's kind of the weakest one. It's a syrup that you take and drink. And these other ones, ispagula husk and macrogols, they are more second line. And they usually come in a sachet, which you would dissolve in water and then drink. Now, all of these are going to work by bringing water or trapping water in the intestinal lumen. So these substances, they all get trapped within the intestinal lumen. They don't get absorbed by the intestine or digested by the intestine. And what they do is they cling on to water. They keep the water in the lumen of the gastrointestinal tract along with themselves. And hence they can moisten up stool and make it more easy for it to pass through the intestine. Right. So those are treatments if an individual is suffering from constipation with their IBS. And with that, we finish this video on irritable bowel syndrome. I hope you have enjoyed it and found it useful.